safeguarding access to antibiotics, AMR, antimicrobial resistance, and supply resilience. Ensure sustainable access to antibiotics in both at the public healthcare and a security challenge. In this session, we will connect in One Health perspective on antimicrobial resistance with the broader agenda on pharmaceutical access and supply chain resilience. Our moderator today is Maite Ferrando, CEO of Kveloce and European Commission external experts, and the panelists María Vilar, Casper Ernest, and Enrique Limon Cáceres. Maite is an experienced EU project strategist and innovation policy expert, specializing in health research, digital transformation, patient engagement. She has coordinated multiple Horizons Europe projects and also EU4Health initiatives on health data, citizen science, and cross-sector collaborations, bringing the gap between the policy research and real-world implementation. Thank you so much, Maite, and also the speakers, and I would like to invite you to the stage and wish you all the best in the session. Thank you so much.
Thank you so much for the presentation. First of all, I would like to apologize twice. First of all, because of the small delay due to, this rhythm of the events. And the second apologize is because we also plan to have here Inés Almeida from Portugal, and she could not finally make it. So we will try to introduce some of her perspectives as well during some of the discussions, but unfortunately we cannot have her here. So first of all, let me introduce our speakers, our panelists today. First of all, we have María Vilar. She is Scientific Officer at the European Joint Action on Antimicrobial Stewardship, Antimicrobial Resistance, and healthcare-associated infections, and also Scientific Officer in the National Plan Against Antibiotic Resistance. Also, in particular, she is co-leading the Antimicrobial Stewardship Strategy in Animal Health. María is an epidemiologist specializing in antimicrobial resistance and zoonotic diseases with extensive experience across European agencies and research centers. Her work focuses on antimicrobial resistance surveillance, prudent antibiotic use, and infectious disease risk along the animal and food chain sectors. She is co-leading the antimicrobial stewardship strategy in animal health. I think I've already mentioned this. We also have Enrique Limon Cáceres. He is coordinator of the VINCAT program. I think some of you already know him from the previous panel. From the Institut Català of Oncologia, and she's focused on the surveillance experiences and lessons learned from national reporting systems. He has extensive experience in epidemiological surveillance and data integration across hospitals and public health systems. His work within the VINCAT program has strengthened infection control and improved national data reporting standards on antimicrobial resistance and healthcare-associated infections. And last, but of course not least, we have Casper Ernest. He is Director General at the GARP, the European Healthcare Distribution Association. On supply his expertise is on supply chain challenges and how wholesalers can strengthen resilience and ensure continued access. Casper represents Europe's pharmaceutical wholesale and distribution network with a strong focus on supply chain resilience, medicine availability, and crisis preparedness. He has played a key role in shaping EU discussions on stock management, transparency, and logistic innovations to ensure uninterrupted access to critical medicines. So, just an applause for our great panelists. Well, it is a pleasure for me to moderate this session. And also, I would like to emphasize that the complementarity with the previous session on the impact of the One Health perspective. In this session, we will tackle one of the most urgent and complex challenges in global health, which is ensuring sustainable access to effective antibiotics. Antimicrobial resistance is not longer a distant threat. It's a daily reality that affects patients, hospitals, and the entire health system across Europe and beyond. And not only the health system, we will talk a lot as well on the animal and planet related health. Today, discussions will connect the dots between the public health, pharmaceutical policy, supply chain resilience, among others, and we will explore how to combine surveillance data from human, animal, and environmental health under the One Health perspective with practical measures to secure access to essential antibiotics. The goal of this session is clear: to move from crisis management to long-term sustainability, ensuring that antibiotics remain available, effective, and responsibly used for the generations to come. So that said, I would like to start the discussion directly asking one per one the panelists on some specific questions. So I will start first with María. María, from your position as the European Joint Action on Antimicrobial Resistance and Healthcare-Associated Infections, how can coordinated One Health surveillance and responsible use policies across human and veterinarian sectors contribute to controlling antimicrobial resistance?
Okay, thank you so much for having me here today, and I think this is a nice opportunity to talk about this interesting topic, and also because it's one of the core elements, one of the core objectives that this European Joint Action has, which is integrated all of these aspects. As my colleague previously said, this joint action has different work packages focusing on different topics: surveillance, access to antibiotics, infection prevention and control, and stewardship, plus communication and raising awareness, which are key topics. So I can provide an example of how we are coordinating this surveillance with prevent use, plus guaranteeing the accessibility of antimicrobials. So the work I'm co-leading is the antimicrobial stewardship, specifically in animals, but we are working in parallel in the human sector and in the environmental sector. So the idea or the definition of this antimicrobial stewardship, that could be confusing for many people because there is no a direct translation to your own languages, is that it's a set of actions or strategies with the objective or to ensure the prudent use of antimicrobials, to improve treatment outcomes, right? And ensure then the effectiveness of these products while protecting human, animal, and environmental health and public health. What does it involve? It not only involves the appropriate use of antimicrobials, the right dose, the right route of administration, the right patient, but it also should take into account the 5 Rs, which are responsibility for all actors in prescribing and using antimicrobials, reduction by minimizing the need of using these antimicrobials, refinement when identifying the proper cause or the infection that caused the need of these antimicrobials, replacement, which means use alternatives to antibiotics when possible, and review to monitor the progress of that. But it not only involves this prudent use, but it also involves a coordinated and integrated surveillance of antimicrobial resistance plus antimicrobial consumption. Because having this information, analyzing that information, both from humans and animals, and getting some as well resistance from the environment, could give an important input to design and to help policymakers to design stewardship programs. And in fact, We can talk about the GIACRA reports, which are an interagency reports at European level where they put together data from resistance in humans and healthy animals. Or we can talk about the dashboard that previously Anne mentioned, where we are putting together information of resistance from humans, animals, and the environment. And this could inform us where the problems are, so we can define our use of antibiotics. But also, and that's the third leg of this, is that within this we need to take into account, or we considering the procurement approaches for the availability of effective antimicrobials. And how we do that, obviously, within the JAMRAI, we have a work packaging focusing on which are the priority needs, the priority products that each of the member states have. And we do it that in each member state, they are identifying that antimicrobials that are vulnerable to the market in the human side, and in the veterinary side, we look for those products that are not available, that there is no existence of them, or well, to alternatives like vaccines. And from the JAMRAI, we support these member states to analyze why they are not in the market, and helping them to design interventions to put them on the market the right products to have good stewardship programs. That's kind of overview of.
Thank you so much. By explaining how the joint action works, I think it's a very good example of how these efforts are coordinated. Let's move now also for this warm-up introductory questions to Enrique Limon. Enrique, based on your experience within the VINCAT program, what practical steps can hospitals and national networks take to integrate antimicrobial resistance surveillance data and translate it into measurable improvements in infection prevention and antibiotics provision?
Thank you, Maite, and you work very hard for this table and these days, and thank you to the organization for the second table. And we work together in the same joint action. You can see
I will talk about.
I have a full bag of
pins.
The pins. No, my experience is more about surveillance, antibiotic consumption, and sensibility in the microorganisms. For me, the key is moving in surveillance from passive data collection to active data intelligence, and to do that, we need to standardize and automate data extraction. We need interoperability between hospital microbiology labs, pharmacy systems, and clinical records to create a real-time picture of resistance partners and antibiotic consumption. This isn't just about technology, it's about agreeing on common data, formats, and definitions across networks. Data is useless if it sits in a report. We provide in Catalonia hospitals which benchmarked, actionable dashboards to see the antibiotic consumption. They can see their own rates of specific resistance infections like MRSA or Coccidioides difficile and compare it to peer institutions. This friendly competition, backed by data, directly drives local quality improvement initiative in infection prevention and control. And it's more crucially link this data to antimicrobial stewardship programs, the infection control programs and stewardship programs. When we see a spike in resistance to a specific antibiotic in our network, we can use target guidance to use and promoting rotation or to more effective alternatives. This translates surveillance directly into a smart antibiotic provision, preserving the efficacy of our existing arsenal.
Thank you so much for these clear steps on how to translate this data into concrete tools and support to professionals. Let's move now, and after Casper's intervention, I want to know about the PIN history. But let's wait kind of mystery in the waiting. Casper, how can Europe's healthcare distribution and wholesalers strengthen medicine supply resilience for critical antibiotics? And related to that, what mechanisms are needed to prevent shortages?
Yeah, thank you for having me as well. Thank you to the organizers. It's a good question. For our members, of course, the first thing that we need to make sure is that we have marketing authorization holders who are actually placing it in the market. We cannot distribute what is not there to start with. So that's, of course, an important factor, and it is being looked at the moment at European level. What kind of incentives do we have in place at the moment, especially for the high level new antibiotics? We have a system that is somewhat broken from a financial point of view, because as soon as you come on the market with something innovative, obviously you're being put on the restricted list for very good reasons, but that doesn't really create a market. So this is one of the reasons why we actually don't have the medicine to start with if we need it, and thus we cannot distribute. But in terms of distribution, what we can do is, of course, making sure, again, that for the products that are available in the market, we actually also provide access via the correct procurement systems, via the correct financial incentives. And it's no secret that antibiotics, also for our sector, pose a problem. We have public service obligations, so one can say the public can be sure we will deliver it, and we do every day. But at the same time, we cannot hide that these are products that we are making a loss in providing to the public, and I think that's fairly widely known. And just to make sure that we have a sustainable model all around. Because I do fear that at some point we won't be able to continue that system as it is today. But that said, also in terms of shortages, a lot is being done, and I know we're going to come back on the Critical Medicines Act. So if you allow me, I will save that for a bit later. But there are a number of things that are being done, both in the general pharmaceutical legislation to address the market incentives, and also in the Critical Medicines Act to address more the critical shortages. And we have certainly been part of those discussions. One element we are promoting in the Critical Medicines Act is that in certain situations we should maybe have a controlled distribution. What does that mean? It means that the national competent authorities designate certain players who are actually ensuring the distribution, so that we have equitable distribution, but also to make sure that we don't suddenly have spikes in use in certain areas, because sometimes antibiotic use is also driven by media and other things I'm sure has been discussed earlier during these days. So it is actually quite important that we have someone in the supply chain who is capable of actually together with the authorities, ensure that we are not over, so to say, distributing products as a response to a non-medical increase in demand, if I may put it like that.
Okay, thank you very much. Also, this reminds me to some of the points that also Ines raised on this like a contribution and operation between the suppliers and the, let's say, authorities to ensure the supply chain. I will come to this later. And so after these warm-up questions, I would like to know about the PIN mystery.
Well, it's not a mystery. As you may know, this germ reaction we are working on is the second edition. The first one started in 2017 to 2021. And during that time, our colleagues in communication raised a campaign, a kind of song contest, not song contest, but design contest, because they wanted to raise the awareness of this problem we all have. So they do this contest. There were, I think, more than 500 participants, and it was a Swedish designer who made this design. So they are 2 pills, because it sets the theme, the antibiotics and the antimicrobial resistance. It has 2 hearts, because we care about the problem, and it has 2 aid bands, because it's something that we can cure, that we can solve the problem. So this is the antimicrobial resistance symbol. It is used worldwide. You will see many of the worldwide leaders using it. And I have a bag full of these pins, so if you are interested in having one, they are free, of course. So you can have one.
Okay, of course.
And be one of our ambassadors worldwide.
For sure, I want one. Thank you for. I really love the symbolism of the designers. It's always amazing. And of course, for those of you here, as a kind of reward for lasting until the last session, we will have the theme for us. Okay, so let's move to the discussion questions. We have some questions that I would like to have all 3 of you perspectives. And let's start on this question on how can you, the European Union and national authorities better coordinate veterinary and human regulations to strengthen One Health antimicrobial resistant response. So I would like to start with Maria, but of course feel free to jump if there is some additions, contradictions.
Yeah, I will appreciate that, because I will bring the animal sector point of view. And I would like to highlight the difference between the human sector, patient healthcare, and the animal sector. There are huge differences that we cannot forget, and it will make it makes also difficult to find the harmonization regulations between these two sectors. The main difference is that you are talking about humans, point. We are talking about many animal species, many of them, from cows to fish to dogs, cats, and corals. Imagine how many species we are talking about, and the different types of production and so on. And the other thing, that some of them, the population is so small, or are so limited to small regions, that the markets are very small. So that is a huge challenge we have in the animal sector, and we cannot forget about that. Saying that, how we are addressing those, or within the EU genre, we focus in all sectors. And there is one work package, it's called ACES, where we work with the different national action plans, or with the different member states, for them to identify, as I mentioned before, where there are problems of availability or lack of assistance, like in these minor limited markers we call in the animal sector. How we do it, of course, we have a kind of steps to follow, and we trying to follow exactly the same steps in all countries, regardless which sector we are talking about. Yes, I mentioned to identify which are those products that are critical, relevant, and important in the sectors. Just I have forgot to mention that in the animal sector, we have less availability of antimicrobials or antibiotics as well, because many of them, or some of them, are reserved only for human specific case. So we are even more limited. So coming back to what the EU genre is doing, is having the same approach, supporting all member states to identify, and which are the barriers to put them on the market. And then providing the tools, financial support, regulatory support, and so on. In addition, in some countries, we are working we join forces. For example, there are nowadays 2 kind of groups of countries. Spain Portugal, Ireland, and France, we are working together to facilitate the kind of facilitate the regulation implementation, and also in the Nordic countries have something similar. So yeah, it's a challenge to find this.
And from the supplier's point of view?
Yeah, the challenge is, from our point of view, is that the supply chains are in fact not necessarily the same. So even within human, we may in some countries supply hospitals, in other countries not. So just in terms of data provision, in some countries we would in principle be able to provide, let's say, a bulk of data. The question is then, are we using it correctly? I very much agree with you on that, because we are providing a lot of data on different topics and we don't really see much use of it sometimes. But the second, so that's one question. But do we even have access to the data if we are not delivering the hospitals, and or if we are not delivering veterinary medicines? And typically the veterinary medicines supply chain is quite different from the human medicine supply chain. Few countries with exemptions, but often is direct from manufacturer to healthcare provider. So that's it, as purely as a supply chain issue. Also understanding the complexity that the supply chains are actually different, meaning that we need to bring together more players, which is fine. It's not necessarily a problem. It's just a challenge and a complexity that needs to be overcome. It's a little bit easier in human, especially certain human medicines where we are distributing more or less 99% of everything. Yeah, then you know that once we're in the room together, we have a full overview of the market. So there are complexities also in the supply chain that needs to be considered as we move along.
No, just only to complementary this speaking. In Catalonia, we have in this moment a dramatic situation. We have an health public alert. We have the African pigs flu, and we have restricted limitation for human circulation in Barcelona, in mountain around Barcelona. And this is an example, the link with animal and human relation.
Yeah, but please don't stop eating pig meat,
No.
because it's safe to eat. It's not transmitted to humans. So don't stop buying pig meat.
Thank you very much for the comment, because I was thinking on starting the session mentioning, because of course here in the news, this porcine pandemics or whatever we can call it has been like starting all the newspaper news this morning and in the last. But I also was thinking that maybe it was not fully a topic due to maybe provoking a little bit of resistance. But thank you for bringing this to the discussion. Let's move to the following question, and let's and somehow you mentioned something in the previous response on health, One Health related data. How this One Health related data can connect antimicrobial use monitoring with supply chain planning and policy decision. And here also I have some contribution from Ines, but we will start with Enrique.
Yeah. Human health data on AMR and consumption is a leading indicator for future demand in the veterinary and environmental sectors, and vice versa. If our surveillance in hospital detects a new resistant gene, this intelligence must be rapidly shared with veterinary authorities. They can monitor for the same resistance in livestock of the environment. This allows policymakers and manufacturers to anticipate a shift in demand towards second or third line antibiotics.
María?
Yeah, I fully agree with what you said and support that statement. I think also that is integrated one on the health data, both in consumption and resistance, provide, if possible, real time, that would be perfect. Provide information, just not only to detect the hot spots where there are more consumption and therefore more chances to resistance to appear, but also if you know that there are more consumption, you can expect it somehow that it could be vulnerable, lack of medicines there, so it's kind of informing as well the suppliers and the policies.
Yeah, I think from our side, of course, the use of data and how we can get better at utilizing it. What we see, especially in shortages, is how some of our members start using different channels that maybe we wouldn't have considered years ago to predict demand increases. For example, actually monitoring media. So the simple fact that more and more people start talking about a certain disease or certain things online actually is in some cases a very good indicator of a future increase in demand, which I think we also need to have a conversation with our doctors about, both human and veterinarian. Sometimes it's things that I think we are really seeing new avenues that I think we should explore also in AMR that are quite interesting. They may have been thought of in other scope, but nonetheless we should definitely look at that. But again, once we have the data, a standardized format is correct. It's necessary. We need to consider at what level when we are talking about wholesale. Usually we speak about SKU level. So that means standard stock keeping unit. So that's one pack, one strength, one size of the pack. 24 pills, 5 milligrams. That's a stock keeping unit, and so on and so forth. Is that the level we want to, or are we in? And I know that from the two countries I've lived in for a longer period, that the packs you get don't always correspond to what you need to take, right? So usually your doctor will say you need to take this for 7-8 days or something like this, but actually there are, let's say, 10 pills in the pack. So we need to understand, are we talking dose, are we talking packs and stuff like this? Can be done, but we need to have that and look at European level and have a somewhat standardized approach to it. Because often the pockets of disease is not necessarily limited to a national area, but sometimes, especially with smaller countries, it's cross-border, it can be in a border region and so on and so forth. So we need to have a certain standardized approach to this, and also for the ECDC to work with this at a European level.
Yeah, I think we need in Europe to move in from to reactive to proactive model. This is very important because we are very reactive to the different problems, but we are not in this time proactive to solve the situation.
Exactly.
Okay, let me just act a bit in behalf of Ines to comment to aspects related to that. She mentions that in her experience in Portugal, they are first of all trying to connect the e-prescription, let's say, related indicators with a kind of dashboard alarm system in which when they are like expecting or predicting that it is going to be a kind of limitation of shortage, there is a direct connection with distributors, with providers. And even they are going one step further, trying to interconnect the data sets from the, let's say, demanders, the users, the hospitals, the regions, the authorities with directly distribution stocks and so on. So I think this is quite a relevant initiative and probably aligns very well with your mention before on this need for direct data and direct connection. Also, she mentions.
I think on e-prescription, that is quite powerful data in terms of demand forecast. But and also again, frankly put, a feedback loop also to the doctors, which are key. As supply chain stakeholder, I have to make it very clear. If a doctor has made a prescription for a patient, not only do we have in most countries a legal obligation, so to say, to supply that to a pharmacy or hospital, but we also feel a moral obligation because we are but we are not the healthcare professional. So if a healthcare professional has said you should get that medicine, it's my job to get it there, no matter what. So we have to be clear that on one hand, we are really very aware of our role as a very concentrated sector. We have an enormous knowledge and power in terms of actually distributing things, but we have to have that conversation with doctors. So for us, it's also when we have an e-prescription system that it has a feedback loop to the doctors. We saw after COVID that we saw an immense overprescription of antibiotics for virus, right?
That's true.
And this is something where if the NCA, the National Competent Authority, asks us to do something specific, okay, we are a little bit more on safe ground, but I have to say as long as someone is prescribing it, it is our duty to deliver it. So the only thing here is again and this is why we talk a lot about collaboration and partnership and so on, because it actually requires a lot of different functions coming together that we can't do this alone.
Yeah, just to add to what Ines mentioned on this e-prescription in the animal health sector, there is this European regulation for the medicines where it says that all prescribed medicines or antimicrobials should be recorded by animal species, so we have already those data at real time. I mean, this regulation is at the European level, then each member state adapts and put in force on their own characteristics or particularities. But for example, in Spain, we are, since last year, the system changed, we are reporting every single antibiotic electronically, real time, that is dispensed by the pharmacy. So it's at individual real use level. It's not the prescriber, but also who sells. So it's real use, not only prescribers, because sometimes one thing is prescribers, but it doesn't mean that it's exactly usage. So there is a kind of gap in between, and we collect in the animal health sector this information for all animal species in whole Europe.
Okay, let's move now to one related question, because we are talking about regulations, and one of the most relevant one here is this Critical Medicine Act. So I would like to ask you what lessons from this Critical Medicine Act can be applied to ensure supply chain security for antibiotics and other critical medicines, but in particular for antibiotics. Yeah, and I would like to start with your vision, Casper.
Yeah, thank you very much. I think the Critical Medicines Act in itself very much focuses on in terms of antibiotics, or not necessarily AMR as a concept, but rather the effect that we have seen on critical medicines in general, about low prices. That has become a challenge. There we see the Commission proposing the use of public procurement in a different way, so having the possibility to have buy European, for example, or making sure you have a diversified supply chain, meaning you have more than one active ingredient producer downstream to the marketing authorization holder, different things like this. I think these are, in terms of antibiotics, some of the right tools to look at. There is an issue on pricing. So that's good. It has to come with conditionalities, of course. If we pay more, we have to actually get that supply security. And I can tell you it is frustrating. It costs us a lot of money to deal with shortages every year. Whenever something is in shortage, the first one anyone calls is us. What else do we have? What do you have in stock? What's possible? Can you get it from another country? And so on and so forth. That actually costs us a lot of money. We do it, but it's not exactly part of our automated warehouse and ordering system process. So we are very keen to address that part, and we do see that especially very low cost, old molecules, and often especially in slow-moving products are the issue, and some antibiotics, especially the ones we talk about, do actually fall within that scope. So the Critical Medicines Act is addressing some of that. We are trying to ask for the possibility in certain situations that we actually introduce some form of controlled distribution on that. We'll see if we are successful with this. But then I think we have to mention also the general pharmaceutical legislation, because it is also under negotiation in Brussels. And this is where at least there is an attempt to really tackle the market incentives, as I mentioned the first time. The fact here is that supply and demand incentives are not, unfortunately, matching. So first and foremost, the general pharmaceutical legislation is trying to tackle the supply side of things, that, as I mentioned, if you are doing research in new molecules, if you actually come to a result, it will usually be put on the reserve list, meaning you have a very, very, very small market, hopefully for a long time, right? Hopefully we don't need those for a long time, but you have still invested a lot in that research. So therefore the market incentives for AMR doesn't work at the moment. Commission has proposed the transferable exclusivity voucher, the TEV. Other models have been proposed as well. We'll see where the Council and the Parliament ends up. I'm not entirely sure at the moment. This is one of the discussion points. A fund has been discussed, other things, you know, a financing by industry where they pay a certain percentage of their profits into a fund and stuff. Many creative solutions. I think just as a bit, you know, looking from the sideline, we're not producing, we're not doing the research. We just have to find a solution to this. There is a disconnect between on the supply side.
May I just, because one of the comments coming also from Ines, sorry, I have to play this dual role already, and also discussing. It's there in Portugal. They have implemented this outcome-based reimbursement, where you do not reimburse the supplier based on the volume of the antibiotics but on the effectiveness, on the results obtained in a given population. How is your the perspective there is that it could be a solution for this, let's say, unbalance that you were just mentioning. What is your perspective on that, or not only you, but also the others?
Yeah, I don't want to make myself the judge or the expert on exactly which model is the right for the reimbursement or for the financial incentive. We see in other in the discussion there is also just a minimum, let's say, minimum reservation of minimum purchase and stuff like this. There are many ways of doing it. Some come with caveats that suddenly you have products that you don't need in the end, so you have waste, or so on and so forth. I think here we have to be really flexible and potentially innovative in the different models we find, and perhaps do things a little bit different. I think at the end of the day, when we're talking about really new groundbreaking antibiotics, and those that go on reserve lists, that is not where we spend the bulk of our money. So I think if we need to incentivize that is resources we could find, considering the scope of this problem. But of course, AMI is one of those, we call it silent killers. It just doesn't get the urgency of other things. Yeah, but it doesn't, right?
Yeah, that's true.
It's true. If we look at how many deaths this causes every year, and if we look at the projections moving forward, it's absurd that this doesn't have more attention. I know everyone is trying, who is working with it, but coming more from the political angle, that's my job and my profession. The reality is we have not yet seen a tough enough crisis to actually create that momentum we need. But I think and I hope that we can move at least in part on this, even though we don't and hopefully won't need a crisis before we do so. But I must say, a bit cynically from the distance, more politically speaking, this topic suffers from the fact that we haven't yet had the real crisis. And it's disastrous to think like that.
I would like to make two differences of what have been said in the human part to the animal, if I'm allowed to. First thing about the reimbursement and all these things, it doesn't work in the animal sector. We don't have regulated prices. There is no reimbursement. There is completely different way of how it is. And also that the critical audit does not apply to the animal sector neither. We have this medicines regulation, veterinary medicines regulation, but that's all, and then all the delegates regulations and so on. And the other thing is that in the animal sector, we are not, our objective is not to look for new antibiotics, but to review what they already are. The ones already in the market, well, updating then regarding the dose or the format on the different aspect of it. Why? Because it doesn't it's not appealing to the market holder authorizators, because the limited markets, because the regulation process, to put them on the market. So what the regulation trying to help is to make this a step easier for them, for example, reducing costs in some specific studies for them, or providing other information than doing full report, or helping them to reducing the times and so on. And then, for example, in the national level, we have reducing taxes for those market holders authorizations, that they do these updates, but they also make wider potential market, not only limited to one species, but to deliver to other species. So these are the two main differences. This is not so regulated that is human, and then the regulation and the how we work in the all antibiotics.
No, I think Casper and Maria explained very well the situation. I want to contribute with a political perspective. In Catalonia, we are working in diversify la production. We need to reduce reliance of single geographic source, like China or India, and supporting domestic manufacturing the different antibiotics. We need to control and maintain buffer stocks of essential antibiotic. We have a big problem to have stocks in different moments in the years. We need a transparency political mandate for the people now. What is the use financial tools we need to do this political and to make domestic production of critical medicines economical viable. And we need, Maria speak about that, establish a centralized system to monitor all the situation, the supply, forecast and demand, and coordinate a rapid response to potential shortage.
Thank you so much. We are proceeding in the discussion section. I still have some questions, but I would like to open to the audience the possibility to ask some questions to these wonderful panelists that we have. If not, of course, I will continue with mine. But is there any question in the audience? No? No? Okay. I will move on with, let's go to one of the topics that has been discussed a lot during these 2 days, and I will start with Enrique. What role can digital tools, and we were mentioning just right now about these integrated systems to alert, so I think it's quite aligned. What role can digital tools and real-time data play in anticipating shortages and supporting rapid intervention across member states? I will ask you to be very short, because we still have like 5 minutes to...
Yeah, I think digital tools or early warning systems. We need a centralized but federated European digital platform that tracks antibiotic consumption, resistance rates, and inventory levels across member states. Thus, will be transformative.
Super. Any short?
Very short. That's something that we are working in general, and Anne mentioned before that we are in this One Health surveillance. We trying to, first of all, there are different sectors have different ways of collecting data. That's important. So it makes difficult to find the way to harmonize them and then to analyze them. So to have only one database with all data is not so quick or near future, but we are working on it, and I lost. I lost the
digital tools.
Yeah, the digital tools. So creating this whole database and creating a One Health report with all sources of information are there, I think is also key.
Okay.
Yeah, I think from my side, it's to some extent about giving someone the mandate to sit down and do it. I think having followed the shortages discussion in human medicines for almost 7-8 years now, personally, it was, we talked and we talked and we talked and we talked. And all the complexities and everything. And at the end of the day, what's going to make the difference is that we had a legal mandate to EMA to make the European shortages monitoring platform, period. And we have all kinds of tools with all kinds of data and so on that were never designed for this and that, and then we start discussing which tools could we or could we not use. For me, it's irrelevant. If no one has the responsibility and the clear mandate to sit down and get it done, we're not going to get it done. And those people, at least from EMA, I have tremendous respect for what they're doing. Rome wasn't built in a day, but they have actually advanced tremendously in a very short time on the shortages monitoring platform. And we are hopefully starting to see the effects of this very shortly. They've just gone live. But also, once you have those people in charge of that, you start seeing the nuances of what is needed. For example, when people say we need inventory, of course, being an expert on inventory, I say that's good. I don't disagree necessarily, but you need then as well absolutely also to know the supply frequency, because some products are fast-moving goods, so I'm supplied every week, very big quantities, so my inventory is maybe 1,000 packs, but it's only for 1 week. It's planned only for 1 week, and I will get another 1,000 next week. Other products, I have 100 in stock, but that's actually stock that I'm only being delivered every 12 months. So those 100 packs are actually intended to last for 12 months. So when you speak about inventory, you need to see, is it slow-moving goods, fast-moving goods? What's the supply frequency and stuff like this, So it's just to say, why am I mentioning that? Again, someone just needs to sit down, have that conversation, and figure out what is actually the data we need and have the mandate to carry it out. No more research projects, no more this and that. Just get it done. Sorry, that's a bit my view, because otherwise we will continue these endless discussions on what data is where and what's right or wrong. It's, at the end of the day, not rocket science. It's not easy. No. It's complex.
And that's what we are trying to do in this genre. Harmonize the different database that all countries have into the same style, so then you can have one tool to compile everything, but first all have to collect the same type of information in the same way, so it's a process.
has to be top-down. We will never generically, 28 countries, start collecting in the same way, the same data, thinking the same direction. Someone has to sit down and say, this is what we need. And then member states will have to follow. That's my point of view. I understand how difficult that is. I understand how it's difficult to then follow the federated models and so on, but this will at least be my voice in the debate.
Well, we are doing it at voluntary basis.
Yes,
this
absolutely. That's why I'm saying,
one
no, but there are many good things finally going on. I want to be clear
Yes,
with that, and
true.
the ESMP and so on. I want to be very clear. I'm not criticizing.
No.
It's just 7 years
It
of
has to be
discussion. In shortages, we only really moved when there was a clear legal mandate for one entity to do it at European level.
That's true.
Okay, I think we have just 2 minutes to close. I will just make a super short summary, but I would like to ask you in maybe 1-2 keywords to close the session. Sorry, I don't that this was not prepared, so it's a kind of final flavor.
Yeah, I will use the same that Anne used. Just improvising in the last moment, and because we work in the same project, and it's one health. we are all important. It's human, animals, and environmental. So the power of B1.
For me, digital tools is the word, and public health security.
Yeah, I think from our side it's definitely about partnership, but under leadership. So mandate someone to have and to take the leadership, so then the partnership actually gets somewhere.
Okay. So perfect, because this helps me a lot to sum up the session. I think, I think what has been clearly pointed out is that there is still a long way to build and to walk through. I think some of the discussions talking about proactivity, this flexibility in the way of funding, this balance to ensure that supply chain it's somehow getting the incentives that they need also to maintain the status of this provision. They need also to put a little bit more emphasis on the integration of the animal perspective into, and I would say also probably the environmental connection or the environmental related data that could be at the end connected with all that. And for all these, let's say, pending challenges, I think this idea of leadership and clear mandates, I think were very appropriated. But also I think that I would like to have let's say, final reflection is this idea about if we are not in front of a super strong crisis, we are not going to react, which I would like very much to avoid, and I would like very much that this kind of discussions and of course the actions behind the discussions would really make that reflection non-applicable, let's say, and that we will not need a lot of people suffering and dying, being honest, to really react. So thank you so much. It has been a super pleasure to moderate this session, and also, as mentioned, representing Ines as much as I've been able to. And I hope to see you in future opportunities like this. Thank you so much.
Thank you.
I try to keep more or less to not delay a lot. Thank you.
So I would like to thank you so much, the speakers, and also the moderator, Maite, that guides us in the very great way about the AMR topic and also the supply chains. Like with the discussions, we've noticed these two thematics are very, very well connected, and we needed to take consideration about it when you talk about antibiotics and also prevention in AMR. even for the veterinary and human, because in somehow they will connect and also affect the human health directly. Now, I just would like to open to announce that we'll have like the closing remarks from our Director of Projects, José Martínez Ozero. He will be doing the closing remarks on the other room, but like he will be streaming here. So I hope that you have had a good time during the summit, and also all the takeaways and the messages that your speakers have carefully prepared to us in order to ensure the security about the different topics on digital health. My name is Anderson Carmo, and it was a pleasure to be here with you today in this room, and also to guide us the session. Thank you so much. In a few minutes, José will appear here behind me in the other side. I'm not sure well what time, but like it will be. Thank you so much.